So in this clinical trial, ABILITY-3, the main question that was asked was whether the continuous use of adalimumab maintained remission more frequently than going off onto a placebo. And what was shown was that 70% of patients maintained remission in those who continued on adalimumab versus 47% on placebo. So this data shows that the success of maintaining remission is greater on adalimumab than on placebo. But I think what's interesting is that about 47% of patients who continued on placebo and withdrew from adalimumab treatment still maintained a remission. And so it would be very interesting to know what might be the predictors of maintaining remission or lack of remission and disease flare. So these are some very important observations from the ABILITY-3 trial. What this data shows actually is that patients should continue to take adalimumab, because at this point in time we don't actually know which patients are actually going to do well if they stop taking adalimumab. That's the problem, is that we do not understand the predictors that maintain remission when you stop adalimumab. So with the ABILITY-3 trial data, it's essentially telling us that it's actually in the patient's best interest to continue to take adalimumab until we have more information of prediction of sustained remission when you stop taking treatment. So I think the hope was that we might be able to predict who would be maintain good remission when you withdraw patients off treatment. But it's quite clear that patients need to continue to take the therapeutic and that we can't stop the treatment. This is very similar to the situation in ankylosing spondylitis, where a great many patients flare, particularly after by a year, 90 to 95% of patients have flared. And so it looks like we have a fairly similar situation in the setting of non-radiographic axial spondyloarthritis. Well, what we see in the safety data is that treatment was administered in that the adverse event profile was in fact very good in patients who were on adalimumab. There's really essentially very few differences from placebo. So there's already considerable experience with the use of TNF inhibitor therapies, and I think that the benefit-risk profile still favors the continuing use of adalimumab in this early category of patients with spondyloarthritis. Further studies would include specifically addressing the role of imaging and whether monitoring patients for major endpoints, objective inflammation endpoints, will be helpful, particularly in terms of structural damage evaluation. So does treating to a target improve outcomes, and does it tell us something about which patients might even be able to go off treatment? It was quite interesting in this trial that when those patients who flared after treatment withdrawal were reinstituted on treatment with adalimumab, that the response after 12 weeks follow-up was not quite as good as it was during the lead-in phase, the open label phase of treatment. In other words, it's possible that if you withdraw treatment and reintroduce treatment, you may not get you may not get the response back.